Welcome to the second part of pulse review. Today I want to talk about arrhythmias, supraventricular tachycardia, ventricular tachycardia with no pulse or pulseless ventricular tachycardia, ventricular fibrillation, bradycardia, and asystole or cardiac arrest. Sometimes we are getting confused when we see the ECG in the monitor. I will try to make it more simple so we can differentiate the normal look of ECG in the monitor and the serious one, which can lead to death if not discovered and treated early. And always don't look only for the number of the heart rate showing in the monitor. You have to see the shape, if it is normal or no, because sometimes you will need to have immediate intervention. We have B wave, small elevation. Then we have the tall elevation is the QRS. After that we have a small elevation. This is the T wave. Between each tall QRS complex we should have two small wave. One is the B and the other is the T wave. If we lost this B wave and this no B wave before the QRS complex, and it is wide, the QRS looks wide and long in duration, and we have it in more than 3 heartbeats in a row, and usually you will find the heart rate at this time more than 100. So most likely there is a problem. And sometimes you can find the shape of, you will find that you lost the shape, the normal shape of the QRS. For the first one, when you find that you lost the B wave and the QRS look wider and the heart rate above 100, most likely you go in ventricular tachycardia. And ventricular fibrillation, you can find there is abnormal shape for the QRS, or there is no QRS complex, and because no conduction for cardiac output, and usually you will not find there is a pulse. If this one not catch early, it can lead to medical emergency because it can make severe hypoxia and can lead to cardiac arrest. And one of the most common causes of this is the severe hypoxia and hyperkalemia. As we can see in this one, in the first we show the normal ECG, and in the second I am showing some ECG from the monitor, started by normal rhythm, then premature ventricular contraction, which lead to ventricular tachycardia, then it lead to ventricular fibrillation, and after that it lead to cardiac arrest. We have I will talk about these scenarios. We'll give case scenario for each one of these arrhythmias. But the most important things I want everybody to know it as a provider. There is something called effective team dynamics. What's the meaning of effective team dynamics? To make your CPR or what you are doing is effective to save the life of the patient. The effective team dynamic, we have 8 elements. The first element is closed loop communication. What's the meaning of closed loop communication? When you give the order, we have to confirm the order, and when the order done, you have to say it was done. Like, I ordered for epinephrine 1 milligram. The one who is giving the medication, you have to say, you mean 1 milligram epinephrine? It was ready. When it was given, you have to mention epinephrine 1 milligram was given. This is the meaning of closed loop communication. Clear messages. The team members have to speak clearly. And when there is any doubt, it have to be questioned. Number 3, clear rules. When the team arrive, you have to give clear rule for every one of them. What he's going to do. For example, if you have the recorder, you have to tell him clearly, you will be the recorder. You have to write all the event. You have to tell us every 2 minutes to stop, switch, and analyze the rhythm. You have to remind us to give epinephrine every 3 to 5 minutes when it is needed. And other orders you want, you have to be clear orders. So, and clear rules have to be given. For the one who's taking care about the monitors, also you have to inform him what he's going to do. And same for all the team members. Number 4, knowing limitation. Anyone from the team, if he need assistance, he have to ask. Like if you are doing chest compression, you are feeling you are tired, you cannot do it, you have to mention and you have to be changed. Number 5, knowledge sharing. Sharing information between the team members. Like if I say, if the dose is supposed to be 2 milligram, I said 1 milligram. Anyone from the team can say, do you mean to give 2 milligram, 1 milligram to correct you in a proper way? With number 6, with good mutual respect. What's the mutual respect? Means to speak in professional, friendly tone of voice. And you have to give positive feedback. Constructive intervention. You can question the one who make a mistake. And you can identify priorities. And the last one for the effective team dynamic is the re-evaluation and summarizing. You have to re-evaluate your patient, summarize the patient condition and the treatment plan. We are going now to start first scenario. For example, you are working like in a pediatric ward and you hear one mother who have a child 1 year old was admitted with bronchiolitis. The mother is screaming and she's calling that her baby is unresponsive. What you are going to do? As we said before, same for the respiratory and shock, cardiac arrhythmias is the same approach. Evaluate, identify and intervene. First, you will have your initial impression. You have to ask CBC, how is the consciousness? is unresponsive. B, breathing, no spontaneous breathing. How is his color? He have pale extremities or you can say cyanotic, whatever the patient have. Then at this time you have to identify. Your identification for patient who is unresponsive, no breathing, and pale color or cyanose, it will be acute life-threatening condition. Then the cycle, evaluate, identify, then number 3 is intervention. Immediately you have to activate emergency response system. You have to start high quality CPR. And you will start providing bag and mask ventilation with 100% oxygen. And the A is applying leads and pads and attach pulse oximeter. When your team arrived, you have to give them their roles and you have to decide what is their intervention, clear rules and their responsibilities. You as a team leader, the first one you have to give him his role is the compressor. The compressor should be hand by hand and no interruption. Then you have to inform them about the case that you have this baby who's 1 year old and admitted as a case of bronchiolitis, and you found him he's unresponsive and he's not breathing, and you start this high quality CPR. After you give for the compressor, then you give for the one who is responsible from the airway. Tell him to open and maintain the open airway and provide back and mask ventilation by 100% oxygen. Then the monitor or the one who is responsible from the monitor, ask him to bring and operate the monitor if there is no monitors besides the patient. And if the monitor is ready, he should put it in a place so it can be seen by the team leader and the most of the team. And once it was ready, it have to be opened. After that, you will give the one who is responsible from the vascular access. You inform him to make 2 trials for vascular access. If failed, to go for interosseous. If failed, to go for endotracheal medication if needed. The recorder, you have to inform him to record the time of intervention and medication, and to inform you every 2 minutes to stop, switch, and analyze the rhythm. And you have to record the frequency and duration of interruption in chest compression, and to communicate this to the team leader and the rest of the team. The team leader have to stand at the end of the bed. After this one, you start your CPR. You are looking for your team members. You have to encourage your team members to perform high quality CPR. Ask them to push hard and at least 1/3 diameter, anteroposterior diameter of the chest, and push fast, more than 100 per minute, to minimize interruption in chest compression to less than 10 seconds, to allow for complete chest recoil between compression, and do not lean on the chest between compression. And they have to stop and switch every 2 minutes or sooner to avoid fatigue, but better switching when you want to analyze at the same time. You have to tell the one who is responsible from the airway to avoid excessive ventilation and to deliver breath over 1 second that produce visible chest rise. Once the monitor ready and it is open, you have to analyze the cardiac rhythm. If you saw there is a flat line in the monitor, you have flat line protocol. For flat line protocol, you have to increase the amplitude. Why? Because sometimes ventricular fibrillation looks like asystole if the amplitude is low. So you have to increase the amplitude. You have to check the connection, because sometimes it's not connected, or during chest compression it is disconnected, so it will give you flat line, and better to change to lead to the lead 2. You continue CPR. You, as a team leader, you have to supervise your team. You have to make treatment decision. You have to provide feedback to the rest of the team as needed. You have to assume the responsibility for the rules. And you have to visualize all your team members. And no team members allowed to leave during the code except to protect his or her safety. All of them should be there. And you have to avoid a lot of people being around. You need 5 team members. Sometimes you may need other member, number 6, just to take information from the family or to explain for the family what is going on. If you have found a lot of people around, you have to explain for them that you need only 5, maximum 6 people around, not more than this. After you finish the first cycle, you go for the second cycle and you are doing effective team dynamic. You can consider to give epinephrine in the first cycle in a dose of 0.01 milligram per kg through the vascular axis interosseous or interosseous line, or if failed to find vascular axis or interosseous line, you can give it through the endotracheal tube 0.1 milligram per kg of epinephrine. Whenever 2 minutes passed, the recorder will remind you to stop, switch, and analyze the rhythm. And if epinephrine given in the first cycle, it will be good. If not given, you have to give it in the second cycle, and you have to check for the reversible causes. Reversible causes, very important in pediatric patient, and most of the cardiac arrest in pediatric due to hypoxia or hypovolemia or hypo or hyperkalemia and acidosis. When you want to assess the reversible causes, better always to start from up. Start by hypothermia, coming after that hypoxia, going checking pulse during chest compression. If it is matching with chest compression, this means it is you excluded cardiac tamponade and you excluded cardiac tamponade and tension pneumothorax. After this one, after you exclude by pulse, checking pulse during chest compression and it is matching, coming for hypovolemia, check if there is any crepitation in the chest. If there is no crepitation in the chest, this means there is no hypervolemia. You can give 1 dose of normal saline crystalloid, 20 ml per kg as a bolus, going for down, checking for blood gas for acidosis, and checking the chemistry, check for hypo or hyperkalemia, sending blood sample for toxicology, and go down checking for any signs of trauma. And you have to check all these cardiac reversible causes, because the reversible causes, if reversed, patient can improve and you can treat the cause of cardiac arrest. Every 2 cycles, as we said, you have to stop, switch, and analyze. If you have any resistance at any time in the airway, you have to intubate. If patient not intubated in the second cycle, once you give epinephrine, you have to consider endotracheal intubation. And better, the most expert to do this one. This is the first scenario for systole. Second scenario will be ventricular fibrillation or pulseless ventricular tachycardia. You are working in the emergency department, and they bring one baby, and he's apneic and gray color, and they are screaming. First, you have to start initial impression, evaluate CBC, consciousness, he's unresponsive, breathing, he's not breathing, color, he's pale color. Identify, it is acute life-threatening condition. Your intervention. So 4A's, activate emergency response system, announce code below, and start high quality CPR. Provide back and mask ventilation with 100% oxygen. Apply bleeds and pads and attach pulse oximeter. You check the pulse and you identify the patient in cardiac arrest. Once your team arrived, you give clear rules and responsibility as we mentioned before. The monitor was opened. You analyze the cardiac rhythm. If you saw this irregular rhythm, like the one here, it is showing ventricular fibrillation. Immediately you have to attempt defibrillation at 2 joules per kg as soon as your defibrillator is available. And after making this defibrillation, you resume your CPR, and you have to attempt to identify reversible causes of arrest, H's and T's, and do not interrupt the resuscitation. After, you have to ensure that you have high quality CPR as we mentioned before. Every 2 minutes you have to stop, switch, and analyze the rhythm. If you analyze the rhythm after 2 minutes, still there is ventricular fibrillation or pulseless ventricular tachycardia, you have to make other defibrillation with 4 joules per kg. And you have to consider advanced airway if you are unable to provide adequate ventilation with back and mask device. After the 2 shock, you have to give epinephrine 0.01 milligram per kg of 1 to 10,000 epinephrine. You can give it intravenous or interosseous, and better to be given during chest compression. You can give it at any time after the second rhythm check, and followed by saline flush. You have to repeat it every 3 to 5 minutes during cardiac arrest, or this ventricular fibrillation or pulseless ventricular tachycardia. After this one, you give 2 shock and 1 epinephrine, and still the patient you find after 2 minutes is still in ventricular fibrillation or ventricular tachycardia without pulse. You give antiarrhythmic medication like amiodarone 5 milligram per kg, and you have to give up to 2 doses of amiodarone till the patient retain spontaneous circulation. If the patient have retain of spontaneous circulation, you have to titrate the oxygen to maintain the saturation between 94 to 95, and you have to initiate post cardiac arrest care. Third scenario about bradycardia. If you are working in a pediatric department and you hear a mother of a 5 years child who was admitted because of seizure, and she was taken to MRI where sedation was given. After that, returned back, and the mother is screaming and she's telling her baby is unconscious. So as before, you evaluate, identify, intervene, your initial impression, evaluate, CBC, consciousness, he have decreased responsiveness, breathing, he have shallow respiration, like gasping, color, he have pale mucous membrane. Immediately here you will identify acute life-threatening problem. Your intervention. You activate emergency response system, 4A's as we said, activate emergency response system, announce code blue, provide vacuum mask ventilation with 100% oxygen, attach leads and pads and turn monitor on, attach pulse oximeter. Once your team arrive, you have to give them clear roles and responsibility as we said. Want to take care about airway, chest compression if case it is needed, vascular access, monitors, and the recorders. You go for the primary assessment. You check the pulse, there is a pulse, but you have a weak pulse. Immediately after you attach the monitor, you did everything. Before you start, don't go for CPR. Check the pulse. There is a pulse, but the pulse is low pulse. You can see it. You have a low pulse in the cardiac rhythm showing heart rate of below 60, like 50. You have to do your primary assessment, go for evaluation, start ABCD as usual. A, airway, you have snoring noises, breathing. His breathing is not regular, it is shallow breathing, and he have a respiratory rate of like 6 per minute, and there is very poor chest rise. His oxygen saturation with vacuum mask now is improving, and it is going to around 90 per minute, and there is good bilateral air entry, and there is chest rise with back and mask ventilation. ABC as we said. C, heart rate about 50 per minute. Ask central pulses are present, but he have weak peripheral pulses. You have to ask about capillary refill time. Capillary refill time, as we said, the normal between 2 to 3 minutes. Here capillary refill time about 4 seconds. Now you have problem. Capillary refill time is prolonged 4 seconds. So your baby is not stable. You don't need to go for blood pressure. You don't need to go for the disability and exposure. You have to identify here your patient. He have bradycardia. He have poor perfusion. Here you have to initiate high quality CPR. The difference between this and cardiac arrest from the start, you have no pulse, you start CPR. But for bradycardia, you start the CPR after you identify that you have poor perfusion. You initiate high quality CPR, same as before as we said. You analyze the cardiac rhythm, sinus bradycardia, and you assess the heart rate response to ventilation and oxygen administration. Maybe because the cause only respiratory. Then go for the secondary assessment. Take full sample history. as before, signs and symptoms, allergy medication, past medical history, last meal event. Go for physical examination, vital signs, and head-to-toe exam as before. You identify bradycardia with poor perfusion. Your intervention, you continue with CPR, look for reversible causes, give epinephrine 0.01 milligram per kg followed by saline flush. And you consider antidote to the medication given if it's related. And you can prepare for intratracheal intubation. And you take consultation from cardiologist and from ICU team. The last scenario is supraventricular tachycardia. You are called to see a baby who have irritability. He is 9 months old. He is lethargic and he is pale. And he is tachycardic. Mother is feeling he have palpitation. Go for initial impression, CBC, consciousness. He is sleepy, breathing. There is increased rate and effort. Color, he have pale and mottled skin. You identify at this point patient acute life-threatening event also, possible respiratory distress, and possible he have shock because he is pale. Your intervention 4S, activate emergency response system, apply oxygen via non-rebreathing mask, modified oxygen, attach leads and pad and turn on the monitor, and attach pulse oximeter. Go for the primary assessment, A, B, C, D, E, as we said. A, airway, check if it is clear, maintainable. If there is any secretion, you have to suction. If not maintainable, you have to head tilt chin left. Breathing, check for respiratory rate. Respiratory rate, he mentioned like around 70 per minute. Respiratory effort, there is increased intercostal, there is subcostal intercostal recession, and there is nasal flaring and head bobbing. Saturation 90. There is crepitation, bilateral. And after you finish the breathing, ask about circulation. Go heart rate. His heart rate around 250 per minute. Central pulses are present and adequate peripheral pulses. Ask capillary fill time 2 to 3 seconds. And he have pale skin. His blood pressure around 80 to 60. And in the first video for pulse review, we give the normal blood pressure for the patient. So it have to check if it is normal blood pressure for his age or no. Check after A, B, C, D, E. As we said, D, disability. He's conscious, he's awake, but looks sleepy. Exposure, check his temperature, check his blood glucose. You identify at this point respiratory distress because there is increased effort, there is increase in the rate, there is desaturation. So respiratory distress and tachycardia. Intervention, put the vascular axis, analyze the cardiac rhythm. It is showing supraventricular tachycardia. But here we have to check if it is adequate perfusion or no. As long as his blood pressure is maintained and capillary fill time is normal, this means there is adequate perfusion. How to know it is supraventricular tachycardia? B wave is absent or abnormal. Heart rate in infant means below 1 year, more than 220. And for child above 1 year, more than 180. Heart rate not variable with activity, because sometimes child crying, you can find heart rate above 220 and he's not febrile. So heart rate not variable with activity. RR is constant, not changing. You go for secondary assessment, sample history and physical examination. After this, you identify cardiac arrhythmia, Supraventricular tachycardia with adequate perfusion, you have to perform vagal maneuver, eyes to face, sparing a nose or a mouth. You will put it for 10 to 15 seconds, and you verify vascular access. Prepare adenosine 0.1 milligram per kg. You have to give it by double bolus technique because you need it to be rapid. You cannula by two-way cannula. In one side saline flush, and the other you will give the adenosine. The time you give the adenosine, immediately you follow it by saline flush and raise the limb. Rapid bolus technique. Bolus followed by rapid and saline flush. If no response to initial adenosine dose, consider and prepare for second dose of 0.2 milligram. It will have to be double, 0.2 milligram per kg. Again, followed immediately by saline flush by double bolus technique. After these two, you have to prepare for synchronized cardioversion. You have to be sure when you put it in synchronized and the light is flushed, 0.5 to 1 joule per kg. If no response to adenosine, or if at any time you found there is inadequate perfusion. After rhythm conversion, monitor for any signs of heart failure. In the start, if he said you found any feature that there is inadequate perfusion, like the blood pressure is low or capillary fill time more than 3 seconds, you have to start with cardioversion, synchronized cardioversion. You have to give, before giving adenosine, you have to start by 0.5 to 1 joule per kg of synchronized cardioversion. I hope I explained the cardiac rhythm well, and thank you.